try to be as possible less than 10 minutes to give time for all colleagues for the talk. Dr. Ahmed will talk about their experience in Egypt and a very important roadmap, how we will start. Let us listen together. You can
have
do
the
the
pointer?
screen easier.
Pointer.
Next.
Assalamu alaikum.
Walaikum salam. Slide.
Thank you so much for this nice introduction. I'm really so happy to be with you during this panel discussion, discussing how to restart a program of living donor liver transplantation in Sulaymaniyah or in your beautiful city. Just I have a few slides concerning transfer of experience in living donor liver transplantation, feasibility, and lessons. As you know, I'm a professor of liver surgery and liver transplantation, as you know, and I'm a program director in one of the military hospitals performing about 40% of the overall transplantation traffic in Egypt. I'm the president of the Egyptian Liver Transplant Society and secretary of the Pan-Arab Liver Transplant Society. Transfer of experience, as I told you before, transfer of experience in the field of liver transplantation. I'm highly interested in this title. As I told you, when we recognized in Egypt the first case of living donor liver transplant performed in 1991, it was not successful. That's why the program was paused for more than 10 years, sorry. And in 2001, two big hospitals in Egypt, one military and one private hospital, with full support from the authority, they recognized at first that liver transplantation is a program. It needs a multidisciplinary team with complete understanding of the minor steps of the operation. And the second most important step, this program, never to be run by the local team alone. They need transfer of experience from another team with a huge experience in this operation. It's very difficult operation, a lot of details in the donor and recipient operation. You have to start with a reference, with a good reference, to be easy to launch your program for the society with a good results and to move forward later on. And when you move forward, always you will need a reference with a huge experience in liver transplantation, as not the patient to pay the cost of your learning curve. This is my collective opinion. As I told you, we recognized at that time in 2000, and that liver operation is a program. We started collaboration with the Hôpital Édouard Herriot in Lyon in France, and our team in Hôpital Wadi Nil. At that time, we have a nice study about the transfer of experience and analysis of the effect of learning curve in adult-to-adult living donor liver transplantation. As you know, prior transplant training and minimum educational background in hepatobiliopancreatic surgery and hepatology is mandatory. In countries like Egypt at that time, without cadaveric program, living donor liver transplantation can be rapidly evolved only in reference to other established centers. And this the photo of one of our cases, donor operation, bloodless field, transecting liver at the cantle line, in one of the very early beginning cases of adult-to-adult living donor liver transplantation. I think this slide, this is the summary I can give to you concerning the roadmap, how to start a program or to restart a program of living donor liver transplant. You need a center for living donor liver transplant. You need financial support. You need to establish partnership at different levels, governmental, international institutions, university hospitals, medical and surgical teams. The most important part is the training and educational programs. It's not only the surgical part which is important and need gradual transfer of experience with gradual hands-on between the local team and the visiting team. No, one of the most important part is, for example, a pathologist, interventional radiology, how to do downstaging for hepatocellular carcinoma, interventional radiology post-operative for cases 30% in the center of excellence performing living donor liver transplant, they have biliary problem. You have to search for a very good endoscopist doing ERCP especially in unsupported biliary system in cases of living donor liver transplant. Very good endoscopist, very good interventional radiology to do a lot of rendezvous operations in cases of biliary problems. The same interventional radiology performing a lot of vascular complications could be encountered post-operative. You need in a qualified and specialized medical and surgical institution, trainers from different specialty. As I told you, it's not surgery only, it's hepatology, hepatobiliary, transplant, pediatric hepatology is very important, transplant surgery, intensive care, pathology, immunology, and internal medicine. Training ideally for 1 year, very collaborative work between the local team and the visiting team, and starting clinical program under responsibility of the multidisciplinary team. Progressive transfer of experience will happen later on. This is one of our cases, one of our late professor, Dr. Ala Faiz, and Olivier Boileau, with just, as I told you, gradual hands-on, many parts in this operation, the donor operation, many steps, mobilization, pedicle dissection, resection of the liver, all these steps, as I told you, the donor or the recipient is not the one to pay the learning curve or this part with the gradual hands-on between the local and visiting team, as to have no compromise on the operation or on your results. Our paper on transfer of experience, we concluded that living donor liver transplant is considered the standard procedure in adult-to-adult living donor liver transplant, and of crucial importance in countries in which cadaveric transplantation is not yet feasible. Transfer of experience is possible and avoid most of the serious complications and bypass part of the learning curve of this difficult procedure. After 40 collaborative procedures and 20 own cases, results do not significantly differ from those of experienced centers, even in more difficult cases. We have the same journey as we have the first journey between the French team and our Egyptian team 23 years ago. We have the same journey with Kingdom of Saudi Arabia. We started to prepare our checklist and to prepare a team for liver transplantation in Saudi German Hospital in Jeddah. It's, as I told you, SCOT, or Saudi Council for Organ Transplant, to have a license for the hospital to do liver transplantation, especially in a private hospital, it is a very hard task. But we succeeded after 11 months to prepare all the needed instruments and devices and to have the setup ready to do the operation with all retractors needed, microvascular instruments, donor and recipient instruments, and then we have the license from the Saudi Council for Organ Transplant that this center on personal level and on setup level can do this operation. We started first case of living donor liver transplant with the local team and with our team, and we have this, I think the second or third case of liver transplantation, cirrhotic liver with hepatocellular carcinoma, and then after 3 or 3.5 years, we have a team from different Saudi teams and Pakistani, Indians, team can perform, and this is the most important part, this team can perform nearly the majority of hepatobiliopancreatic surgery. Now they do a lot of pancreatectomies, Whipple operation, clad skin tumors, hepatectomy, even extensive right hepatectomy or extended right hepatectomy, they can do alone, and they can perform straightforward cases of liver transplantation, not the pediatric and not advanced cases, but they can do the majority of the major part of this part of the operation, and this one of our cases celebrating this donor giving her father the right lobe post-operatively, just one celebration. We repeated the same story with one of the African countries. We have a phone call from one of our friends, the head of the department of Trijville Hospital in Hôpital Abidjan in Côte d'Ivoire, asking us to make the same story in Abidjan with the help of the WHO concerning the financial part. And we started to visit all our team members, this Dr. Amr El-Fouli, our talented endoscopist, visiting Trijville Hospital, Dr. Ahmed Mukhtar, the intensivist, and this Dr. Kili, the professor of hepatobiliopancreatic surgery and liver transplant. He trained for cadaveric transplantation in the USA for several years, and he asked us to start with him doing living donor liver transplantation in Trijville Hospital. Many visits from their interventional radiology, pathology, even the nurses, surgical team. They visited our center in Egypt. We are performing nearly 2 to 3 cases per week. And they visited our team, having a lot of virtual meeting and Zoom meetings. And then we started to prepare a center, the cardiological center. Usually we follow the setup of open heart surgery. They have all the necessities for especially the intensivist and the ICU. And this is the hôpital cardiologique. We started the cases of transplantation at this hospital during one of our visits. And we start to prepare all the needed requirements, a lot of meetings. This is Dr. Kelly preparing the cases, donor and recipient, and discussing all the details concerning the radiology, pathology, biopsy of the donor, every single step of the operation. The majority virtual, and sometimes we are in need to visit them in person. And then we performed our first case of living donor liver transplant. A donor, during the surgery, we have a break now. And this is a donor that 1 day after the operation, at day 1. And a few weeks later, he's performing his normal life, and this is his mother giving her his right lobe of the liver in a very good shape, no ascites, no encephalopathy. She has 2 focal lesions, hepatocellular carcinoma. Now she's completely normal, even dancing, performing all her activities. And surprisingly, you have this is the Minister of Health, and this is the representative of WHO, Professor Kelly, and my team members after the launching of the program in Trijville Hospital. And we have a nice celebration with the Prime Minister, Professor Patrick Achi. He has a very good, he told me when we have this celebration, that's the most important issue in his program, that the Prime Minister before him, he has post-hepatitis B cirrhosis and hepatocellular carcinoma. And all the country, and even the 9 countries in the west of Africa, no programs for liver transplantations. That's why the first task of this Prime Minister, Patrick Achi, is to start a program of living donor liver transplantation in his country, preparing his team and the major the University Hospital, Trijville Hospital, to perform such operation. Thank you so much. This just continued collaboration, Dr. Kelly, in our first international Congress of the Egyptian Liver Transplant Society, and he's celebrating with us, and this all team members of Abidjan with us in our gala dinner. And take-home message that living donor liver transplant is considered the standard procedure in adult-to-adult liver transplantation. It's a teamwork. As I told you, maybe before, transfer of experience is possible and avoid most of the serious complication and bypass part of the learning curve. 40 collaborative, 20 own cases. I think the local team can perform this operation successfully. Thank you so much, and many thanks to my team members.
Thank you very much, Professor Abdul Al, for this nice presentation and summary of your beautiful journey and achievement. Hoping you more success. Now I ask our colleague, Professor Fakhar from Shariati Hospital, Tehran, to talk about also their experience in Iran about liver transplant. Professor Fakhar also is Professor of Hepatobiliary Surgeon and Transplant, liver transplant. Yes, please.
Okay. Good afternoon. I know everyone is tired, and try to finish it as fast as possible. History of liver transplantation in Iran returns back to 30 years ago. Who started liver transplantation in my country is Professor Malik Hosseini. He trained by Professor Starzl in Pittsburgh, and returned back in Iran and started the liver transplantation with his friend. I am the 3rd generation of transplant surgeons of Iran, and have chance to train by Dr. Malik Hosseini in my original country. Liver transplantation, sorry, I returned back, okay. to have a program for liver. In my country, most of liver transplantation is from the cadaveric donors. And this happened by, with that work did by Dr. Malik Hosseini and his teacher, Professor Fazil, to discuss with religious mans and governor and this people, media, and establish this liver donation within the country. Nowadays, everyone in my country have one donation card. And without permission, they can give their organs to others. But still, we have living donor transplantation, even for Iranians or foreigners, especially for children. To have a transplantation program, we need three parts: physicians, hospital, university. University is not mandatory, but usually these programs start from university hospitals. Physicians who are within the game and is mandatory for transplant program, or one program directors usually start from surgeons. One surgeon is program director, or one hepatologist. And the other one is transplant surgeons, hepatologists, anesthesiologists. First, when we started liver transplantation, anesthesiologists and intensivists was the same. Even when they started liver transplantation, surgeons and hepatologists was the same. And those who make decision for medication and these things, indications, was surgeons. Now we have all of these subspecialties. And the consultant, the radiologist, the first part is mandatory. Other parts, when you want to go forward and do more complicated cases, you need these subspecialties. Consultant radiologists, infectious, nutritionists, physiotherapists, and psychiatrists. Especially for donor liver transplantation, you need psychiatrists to discuss with the donor the complication issues and take permission for organ donation. The other steps, I told before that transplantation program need teamwork. You need a good team. Even sweeper within the ward is important. Those personnel who take this bottle of suction are very important. If you don't have them, you should stop the program, because you will not do this job. So transplant coordinator, we have one pre-transplant coordinator and one post-transplant coordinator. Our pre-transplant coordinator is a nurse, but post-transplant coordinator is a general practitioner or a staff expert in the field, and this is a dynamic work. You know, in our operation theater, anytime we have at least 2 persons who are learning to be a transplant staff, operation theater, because this is a dynamic work, and they will be tired and leave us. We need new person. Because of this, any time we do, even in the coordinator office, even in this operation theater, even in ICU, even in the ward, we have at least 2 or 3 persons who are learning. Transplant ward staff, post-op clinic staff, and some space to collect data and statistics for the patients, and for publication, presentation, and these things, and social worker. You know, after transplantation, patient need to return back, check lab data, take medications. If you give the organ to someone who can't care the organ, you lost it. It's better to not do this type of transplantation. Because of this, this is a long life program, and you should follow the patient after transplantation. So you need social workers, evaluate the patient, even a sponsor. Any person who come to this after this, this is about the physical space. I saw the OPD clinic, coordinator office, program director office, selection community meeting. We need a room to make every patient one by one with his or her family. In that room, we, in the process, ask the patient to come and discuss with him. 3 operation theaters, one for donor, one for back table, another one for implantation. And these things should be 24 hours a day and 7 days in week. For cadaveric donation, it is an emergency operation. You can't have plan. Many times we were outside the hospital with our families. They called us and we left everything to OR. But for living donation, you can have a program, regular program, make decision. But in emergency situation, you should return and do your job. And this is the process. Hepatologists, gastroenterologists, surgeons, or another physicians refer the patient to our dedicated hepatologist. Someone, others know that he referred the patient to the team. This hepatologist evaluate the patient, is there indication for liver transplantation or not. Then he referred the patient to the coordinator. Coordinator have a checklist. He should fill the checklist and do everything as vaccination, I don't know, this documentation, lab data, imaging, everything. Then after that, patient referred to the selection community. Selection community is this: program director, surgeon, hepatologist, radiologist, coordinator, social worker, psychiatrist, patient with his attendant and family come to the selection community, sit on the chair, and have at least 15 minutes, more than our talk, to ask his questions, explain how is the process, what is the complication, how much is the survival, what will happen after that, how much they should come back and check lab data, check, give medications, who support financially the recipient. All of these things discussed. If everything be okay and patient accepted, then put the patient in the list. After that, if cadaveric liver prepared, then call the patient, usually one night back, and ask him to come to the hospital to receive the liver. Otherwise, in the living situation, they have the donor and came with him in the scheduled time. After the operation, this process of operation and post-op care, but those persons who said before, this patient need follow-up. Follow-up usually do by hepatologist. In a special situation that some complication related to the surgery happened, then they call the surgeon or consult with the surgeon, but all of these things handled by post-transplantation coordinator. We don't wait for the patient to come to us. We ask the transplantation coordinator to regularly, according to the list, call the patients and ask them, do you take the medications? Do you did your lab data? You didn't send this, you should send us 2 days back your lab data, but you didn't send us. What happened? And these things. Thanks for your attention. I think I passed 10 minutes. Thank you very much.
It was so interesting that if you continue, we will not interrupt you. Thank you again, Professor Nasser Al-Fakhar from Iran, for your nice advice. And I think now the roadmap is more clear. You know, liver transplant need some administrative, ethical, and legal issue to be regulated. So we ask Professor Abdullah Saeed to talk to us about the Ministry of Health regulation or advice and administrative and legal issue for liver transplant in our project. Dr. Abdullah.
Dr. Muhammad, as a coordinator of these panels, and thank you very much for your patience, ladies and gentlemen, in this late afternoon. Actually, two of my colleagues talk about the wonderful experience of the living-related donors of liver transplantation from Egypt, and Dr. Fakhar from Iran, he's go through the cadaveric donation as a system. So what we're looking here in Kurdistan is an idea to have how much we can set up a program for, I don't know, it's not working. Okay, the content of my talk will be briefly about the some introductions, primary goal, vision and missions in the Ministry of Health and roadmap, and also medical legal issues and the critical questions. I want to more concentrate on this slide, and later on I'll talk about what I mean by critical questions. Introductions about the liver transplantation, or in general organ transplantation, where we are, the current situation of the Kurdistan. Organ transplantation program in Kurdistan region is a government organization in the level of Ministry of Health. We have a higher committee for organ donation and transplantation, is headed by His Excellency Ministry of Health. And also we have Directorate of Organ Donation and Transplantation, and myself are responsible as advisor in the Ministry of Health for this directorate. The existing transplantation program in the Kurdistan, we are starting by kidney transplantation in 2004, hopefully by the support of some of our colleagues, doctors from outside, especially Professor Dr. Ghazi Zebari. He is a native Kurdish from America. He come and set up the program in both 3 cities of the Kurdistan, in Arbil, Suleimaniye, and Duhok. He helped our colleagues to establishing the kidney transplantation. It started since 2004. We have in public and private sectors kidney transplantations. And just last year, in 2002, we have a near 1,000 kidney transplantation in Kurdistan. So all of them are from living, related, and non-related donors. We have also small programs for the corneal transplantation. It started a few years ago and only on the private sector. We have a bone marrow transplantation for the leukemia, and also we have a lot of cases of thalassemia, as you know, in region. So we are starting the program of bone marrow transplantation in public hospital. We have a center here in Suleimaniye. And the last one is a liver transplantation. Since 10 years ago, numbers of the cases was done in Arbil mainly, not in Duhok and Suleimaniye, and in private hospitals only. What is the goals of the primary goals of Ministry of Health? We want to establish a public national organ transplantation center in Kurdistan region. Looking to the terms, it must be public, it must be national, and one center I think is enough for starting as a public center. And the second one is a starting liver transplantation program, not operation. Please, many of my colleagues talk about the liver transplantation. Liver transplantation is not an operation. We bring one healthy person and one patient to the operating room and doing surgery 10 to 12 hours and then let them go. It is not. It should be established like a program. So the roadmap is the vision and mission in Ministry of Health, as I mentioned, in provision of organ transplantation and donation services for the people. This is the idea is discussed, and we prepare ourselves for these services. We have enforced law in Kurdistan region, the law number 1 in 2018. This law is regulating the matter of the organ donation and transplantation in the region. And also we have 2 regulations. Regulation number 2 of 2018, this is for kidney transplantation. And we have a regulation number 2 of the year 2022 for the liver transplantation. Establishment of National Organ Transplantation Center, as I mentioned, and also development of a strategic plan for liver transplantation program, and then action plan for the starting of the liver transplantation. So, standards of care. My colleague talked about what we need to prepare before starting the liver transplantation. This is the standard operation theaters, medical equipment, surgical instrument, medical supplies, ICU, RCU, central unit, sterilization unit, advanced endoscopy center, intervention radiology, and then the second most important part one is the human resource. What we need from human resource side, different specialties, and all colleagues mentioned about the MDT. This is MDT. We need transplant surgeon, we need hepatologists, GIT surgeons, anesthetists, and so on. And the second part of this human resource, please concentrating on the matter of the academic qualification and also the certificate and the experience of the member of the team. This is a time for looking at the quality. We want to provide the services, but with the acceptable standard quality care for our patient in Kurdistan. Funding of the program, as my colleague Dr. Fakhar mentioned, it needs the support. It's a huge issue, liver transplantation program. Who will cover the support and cover the cost of the expenditures? Kurdistan regional government is completely funding the program. KRG since 2020 paid a cost of operation of liver transplantation inside and outside of country for near 90 patients, and the cost of each of them is $32,000. It was paid by the government, but we don't know what happened to this patient. Nobody has followed him. What was the result? Where they are registered? What complication happened? What they are doing? So what we want from now on to regulating all these issues. We as a government want to take a major responsibilities and part in the liver transplantation program. And we try to starting this program by how can the patient apply for this support of the government. We have a governmental port. We call this is services gov court. Gov is government. We call it khazmat in Kurdish. So services in Kurdish is made khazmat. The patient can apply, go to this online and register themselves, and apply and upload the document that is necessary, and then we give them an appointment. And the second way is they can go to the special scientific committee for liver transplantation in Directorate of Health in Erbil, Soleimani, and Duhok, and they can bring these documents, and they finally decide that this patient needs a liver transplantation. But what we need to do before starting, this is the critical questions that I am mentioned to be answered. Regarding law or religious, which one is important? We have a fatwa. We are an Islamic country. We cannot touch the people's bodies without permission. We have a law, Iraq have a law since 2016, and we in Kurdistan have a law since 2018, but we cannot start the program of the diseased organ donation because we don't have fatwa. Neither Shias leaders, religious leader, nor Sunnis in Iraq supporting the issue of organ donation from diseased or brain death patient. So the donation, it should be diseased or life donation, or both of them, related or non-related donors. Transplantation program, public versus private, single or multiple centers, local or international teams. I will leave these questions and discussion for later on. This is what mentioned Professor Fakhar. This is a piece of paper looking to this, but it was changed in Iran in a matter of organ donation from deceased. This is the Professor Iraj Fazl. He is still is live, I think, yeah. He's a vascular surgeon. He wrote a letter to Imam Khomeini, God bless him, and asking about the permission. Is it possible to people donate their organ after brain death? And the answer is very short, but he changed Iran completely by this few years. He mentioned that if this is helping the other people and the donors are agree, it is permitted. Many other religious leaders in Iran was against him, but because he was a big boss, it is worked. And it was gone till now. Looking here, this is the Hayat Kubar Ulama al-Muslimin. They say the donation is okay. And it is Ajr al-Azim. So it is possible by the Sunnis, pan-Arabic religions, they are allowed to have organ donation from deceased. But this is our great leader, Shia leaders in Iraq. He mentioned it is not allowed to cut the organs of the brain dead person. And still, publicly and culturally and religiously, it is rejected by the whole community of the Iraq, including Kurdistan. So we don't have any religious support to starting the organ donation from deceased one. And this is the organs. They don't need to go with you. Be organ donors, please. Many religious leaders mentioned that the human body should go back to the heart as a unique. How it's come, it should be back. But it is not the right way. If somebody have a minor injury and cut his leg or her leg, what he can tell to the God? And he don't have one leg? So it is repeatedly mentioned today, this issue is not a one-man show issue. Please, colleagues, nobody is Superman. This is not a matter of Superman. We should sit together. We are a very small region, not even a country. So we should be working hand to hand, supporting each other to have a very powerful team, local team, and then asking for help of the colleagues, either from region, from Iran, from Egypt, from everywhere. They have experience to helping us to set up this program. This is my contact information. If you have any question, please, you can contact me. Thank you very much.
Thank you very much, Dr. Abdullah. We agree.
Yes.
Later we will give you.
Yeah, I will send to you.
Okay. Thank you very much, Dr. Abdullah. As you said, liver transplant is not a one-man show. One-man show is a very nice parfum. Thank you. And you raise and shake so many issues. I think later we will discuss them. Issues, multiple hot issues. And I think our colleague can have comment, and almost all of them has been solved, as solved in our colleague countries. The next speaker will be Professor Asad Hassoun. Please, Dr. Asad, he is one of the hepatobiliary and transplant surgeon working in USA and also part-time in Hawlier. He will tell us his experience of transplant in Iraq. Please, Dr.
Story. But before I do that, I would like to thank Dr. Mohammed, the chair, and my colleagues. I am honored and privileged to be here in the front of my teacher, Dr. Makka Hamadi, my colleagues, Dr. Kalendar, my trainees, residents, and fellows. I'm honestly very privileged to be here. My story started, first I graduated from Mosul in 1986. I did my surgical residency at Brookdale University Hospital in New York. Of course, I graduated in 1986, but I did my residency in 1990. And then I did my fellowship in organ transplantation at the University of Minnesota. It was one of the biggest programs worldwide. My training involved all the organs, including predominantly live donor liver transplant in pediatric patients, in addition to kidney, pancreas, and small bowel transplantation. I stayed on staff for 1.5 years, and I took a position at Scripps Clinic in La Jolla as a program director in organ transplant, and I started the first live donor liver transplantation in San Diego in 1991. Then 2 years later, I moved to a bigger center, which is California Pacific Medical Center in San Francisco. And in 2004, the United States government selected 30 physicians from the United States to come and evaluate the medical system in Iraq and try to lift up the standards. And 2 of those recruits have a military background. One is a plastic surgeon, the other one is anesthesiologist. And they said, wait a second, we have a surgeon who's Iraqi in origin. He should be with us. So they recruit me, and I came with them. And we came to the green zone, and we evaluated. There was a big conference at the time, which was complete chaos. And everyone requested from us to give an evaluation. And at the time, my evaluation was stated like, first, you need to build the infrastructure. I went to Medical City Hospital in Baghdad, and I cried because it was shamble. It was a rumble. And then I said, you need to build nursing. They have no nursing. Without those, there is no medicine. They didn't like what I said. I was disconnected from the group. Anyway, at that same time, because I was a liver transplant surgeon, there's a lot of my colleagues, they send patients to me, and I've seen so many patients with liver failure. And initially, when I'm working in the United States, in San Francisco, so yeah, let's work with the Red Cross, and then called my hospital and called some politician, tried to bring those patients to the United States. And I got about 12 patients ready to come, and then they hit a big wall, which is visa. And by the time visa would be issued, most of them are dead. So then it became to me that, well, if I have to help, it has to be me going there. But having a liver transplant is one thing, a live donor liver transplant is another thing. Now this work.
The lower button.
So just to echo what my colleagues and Dr. Abdullah have said, to build a live donor liver transplant from scratch, you have to build an institution. Short of doing that, you have no program. And then these are some of the elements I put down before I show some slides. And why is that? Why specifically live donor liver transplant is unique? Because the pathophysiology of liver disease patient is different. Every single thing you see in a patient you take to the OR for a Whipple or for esophagectomy or for AAA is different. their hemodynamics are different. You think that people who are alcoholic and liver failure, they have a protection for their heart. You're wrong. You know, we thought that, well, they have a low cholesterol. They have vasodilation, so hypotension, not hypertension. And so they don't have atherosclerosis. But all of this is wrong. Eventually, we found that in reality, 20% they have a significant ischemic heart disease. Then you go to a preoperative management, those people will manage differently. An ejection fraction of 60% in a liver failure patient, that's not very good. That's going to be a problem for you during anesthesia. So you need a very experienced anesthesia team to deal with this. And if you give too much crystalloid and albumin and colloid during the transplant, and you're dealing with half liver or 40% liver, you're aiming for disaster. The liver is going to be congested, ischemic, and then you have to deal with a very long post-operative course of management and maybe failure. And then you go to patient selection. The vast majority of live donor liver transplant worldwide, they did not start doing liver transplant in patients with MELD over 30. And if you know what MELD over 30 means, that very sick people. Till now, Edmonton and Canada, they would not do a live donor liver transplant for patients with MELD more than 25. That selection is crucial. If you come to a country, they don't understand that. You know, they bring you a patient with a MELD of 35 or 40, and you expect you to do magic. No, as Dr. Abdullah said, there's no Superman. There's no one single person that could do that job. But hey, how are you going to start? So I came first, and I was touring the country. The first place I came to is Sulaymaniyah. I came to Dr. Qalender. We did some cases here. At the time, I think Al Farouk was just being built. It was the foundation. And then I went down to Baghdad, I went to Karbala, I went to Hilla, I went to Basra, I could not find a single institution that I could even think of to build a liver transplant program. Wonderful. We did, by the way, a major hepatectomies and a Whipples. Anyway, so then one day I get a call from Dr. Muwafaq Al-Rawi, who is a colleague of mine in the United States, and he said, Asa, why don't you go and check a hospital by name of Jean in Erbil? So I came to Erbil, and I don't know anyone in that hospital, and I walked into the hospital, I said, who is the CEO? Nobody knows what CEO is. And I said, I'm a guest, I'm coming from the US, I'm a surgeon, can I see the hospital? And some guy said, come with me. So I said, show me the operating room. I went to the operating rooms. Show me the blood bank, the laboratory, show me the ICU. And then I looked around and said, this is a hospital that I could do a liver transplant in. And I went to Dr. Aso, and I said, Dr. Aso, I think I could do a liver transplant in this hospital. He grabbed my hand and said, I don't know what you're talking about. I have no idea what you're talking about. Come with me to the office. So that's how things started. Now, I have a lot of patients waiting from Baghdad. I have some surgeon in Medical City Hospital in Baghdad and the GI Center, and then, so we collaborated all of this with the International Rescue Committee and the Red Cross, and with a lot of foundation. Then I went back to, a couple of times I came here, I gave multiple lectures because they have to understand what live donor liver transplant is. Nobody knows that. And then I went back, and to make this successful, first you need to choose the best people you work with. So I went back and I chose, I will show that slide later. I chose the best anesthesiologist I work with. I chose the head nurse of a transplant who has the best experience. I chose the best ultrasound technician we have in the hospital. And by the way, I work in the top facility hospital in the United States, very known with their outcome in a liver transplant. And then so I said, and I didn't give them the option. I said, you're coming with me to Iraq to do a live donor liver transplant. And he looked at me and said, are you nuts? That was a time where, you know, Iraq is in shamwar. There's a war, there is violence, there's nothing there. So I said, we could do it. People, they need that. So the first trip and the first liver transplant that ever done in Iraq and in Kurdistan was at the end of 2010. And I got 13 members of my team, all specialists in the ICU, anesthesia, 2 anesthesiologists, technicians, nurses, ICU nurses, physician assistants, and a truck full load of duffel bag supplies, all donated from the U.S. and from my hospital. This is the first liver transplant that was done. Behind is Dr. Bayros, the anesthesiologist, and his partner. In the back was the head nurse, PA, Dr. Laith from Medical City in Baghdad. And this is the best technician we have. And those are the donor and recipient, they're brothers. By the way, this patient is still alive. He is married and have kids. And I've been seeing him every time I come here. It's coming, it's coming. All right, since you talked about that, let me show you. So I know I have only 10 minutes. I don't want to waste your time, and probably I don't need to go through all of this. But since we're talking about Dr. Kalender, Dr. Kalender was a member of the team at the time. He was an instructor. He was giving really nice opinion. He makes laugh during the whole case, and he was with me for the entire first trip. Then he gave up on me. He quitted me. So this is, by the way, this is the team. We're now. Who's that? Really? Anyway, so my colleague talked about the process of doing liver transplantation. The complexity of the liver transplantation include finding the suitable donor for the suitable recipient. Level of disease is important. Quality of the donor is important. The size of the liver is important. The key things are a very good outflow, very good inflow, including arterial, and a safe biliary reconstruction without complication. These are videos. I'm not going to show any of these videos. You've seen with the previous presentation. But the summary of all of this is that you need a good laboratory. You need blood available. The donor operation, the donor should be the safest ever possible. By the way, I have to make this comment, Dr. Abdullah, because the Minister of Health, they require that the hospital should have a KUSA. They should have a KUSA. Now, how many of you use a KUSA, by the way, surgeons? Oh, every single case? Do you have to use it? Do you have to use it? If I tell you, and I have Dr. Mohammed Niazi, I have Dr. Dilshad, I have Dr. Zana, Dr. Faridoon, they all work for me. I have not given a single unit of blood to a donor without using a KUSA. And I have a video, but it didn't get downloaded. Last week, I did a trisegmentectomy, and I used the KUSA, which is one of the top technology we have at our institution. And I said, I'm just using it. And everyone's telling me, what the heck with you? Why are you using KUSA? And I said, because I want to show it to the Minister of Kurdistan that KUSA is not needed for donor hepatectomy. Well, you don't use KUSA for the recipient, do you? I hope not. All right, I tell you what, when I use it. I use it if I have a tumor very close to the major vessel, and I really need to dissect that vein from the tumor. That's what I use it. But to use a KUSA and waste 3-4 hours for what? Anyway, so it's a matter of choice. But when you get someone enforce it on you, not knowing what exactly needed for, that's painful. I have to say that, Dr. Abdullah, I'm sorry. Why don't you send a committee, come and see me doing a donor and see if you need it or not. I will give you a full invitation. Anyway, so just to go over, so biliary problems is a concern. So I selected this case because see how variable we do routinely intraoperative cholangiogram, and this is a case where we have to turn it down. We do the cholangiogram before we do anything else, and this is a donor that we abandoned because we expect, do you know how many duct? One on the left, but we're taking the right lobe, and there's 4 in the right. And so sometimes you don't find that with an MRCP, unfortunately. What the quality of MRCP? Correct. Yeah, that's a technology. Yes, I was going to say. Sure. Donor selection is crucial. This is like a donor with a replaced right hepatic artery. If you take in the right lobe, that's a plus for us. Of course, the size of the artery is important. And then hepatic vein, this is a donor also that we turn down, even though there's multiple hepatic vein, and the transplant surgeon, they love to have a donor with multiple hepatic vein. But the case in this issue, if I take the right lobe, I'm leaving two vein non-dominant with the left lobe, and that's a concern. So sometimes, even though you may have multiple vein, but that could be a concern to you. And then, the intraoperative anesthesia management during the surgery, especially during the anhepatic phase and post-anhepatic phase, could pay a heavy price for you. So you need a very experienced anesthesiologist. The anesthesiologists we have at Gene Hospital, they were trained by the American team for over a year and a half. American team came with me for 5 trips. They trained anesthesiologists, they trained nurses, ICU. We're giving lectures, protocols. We have a transplant coordinator, quality of the donor. Sometimes we do a biopsy. And then this same team right now, we got invited to help start a live donor liver transplant in Trinidad, the Caribbean, and in Ethiopia in South America. It's starting in January. Thank you very much.
Thank you very much, Professor Assad, for your help and
Just
starting.
one thing important I need to say about the fatwa and all of this. You know, we have what's called a non-heart beating donors right now. So that solved the issue. Because I guess religiously, it's not difficult, really.
Thank you. Yes, please, later we will discuss some issue. Thank you again. Okay, for the rest of time, I will give a very short.
I forgot to give you the numbers because this is a very transparent number.
Just tell us.
You need to
Till
see.
now, how many cases has been done?
This is really,
And
that's the main part of the
survival.
talk. And this is very transparent. So
Yes.
you could check with the hospital the data.
Very good.
Because I want you to know that. And in starting the program from scratch and with limited resources, this is the number I have to give you. And we're not hiding anything from anyone so that you would know what is the data, Dr. Janan? So this is the cases that we've done at Gene Hospital. There are 93 cases. The first 13 cases that we've done, that they're with the American teams. And actually we presented the data at the Pan-Arab Liver Transplant Society in Qatar. We got the second award for it. So let's say that's the American team. And we put Iraq as a member of live donor liver transplant in that society as of that time. From 2012 till now, we have 93 cases done at Gene Hospital. Now we have we split it into 3 eras. From 2012 2015, 23 cases. We had 7 cases death, 69.6% survival. The second phase, you could see how progress we're making. 2016 to 2019, we had 78% success rate. And from 2000 to 2023, we have 34 cases, 82.4% success rate. Now, this is the best thing. The last 6 cases, 100% success. So you know what we say in the United States? You're as good as your last case. So we're good.
Thank you. But I think better to mention 1 year survival or other, not.
Yes,
You mean
yes.
this operation survival, surgical? You are right.
This is hospital
Stay.
survival.
Yeah.
And the deaths that we have, I don't have the numbers, but they are not significantly after.
Thank you very much. Whatever the thing, we see improving, and this is hope that with time and improving our experience. Thank you again, Dr. Assad. I ask my colleague, Dr. Abdullah, not you,
Yes, I know.
Dilmani, shortly, if you have any comment on the project, please.
Thank you, Professor Dr. Mohammed. Thank you for my colleague and my audience. This is a very important issue. We heard and listened from foreigner experience. We have local Ministry of Health vision and mission, and we have Professor Dr. Assad. He works in our country. Really, I want to highlight that we are a local area. We don't need too much centers, really. we should have a proper program, and we should, as our colleague said, we should depend on the foreign team and also to build up a local team. And thanks for all efforts from I20 who participate in liver transplant program.
Later we will ask our colleagues, for example, how many centers of liver transplant in Egypt?
This is a very important question because I usually say that we have many centers, but we have very few teams. I'm a university professor. I'm obliged to work in the university. If you ask me what to choose, I choose to work in one center, the military center, which I developed completely. But I have to work in another governmental hospital and another university hospital. So we have a lot of hospitals performing, a lot of hospitals having license for liver transplant, but in Egypt we have only 4 or 5 teams performing this living donor liver transplantation.
Thank you very much. Very good point. The 4 you
military,
mentioned.
military, it's a private, it's a military, but it accepts the private cases.
Professor Fakhar, in Iran?
In Iran, there is no private transplant program. This is the rule of the Ministry of Health.
Yes, okay.
And because total package of liver transplantation paid by the government, and patient don't pay anything, even for the donation, evaluation, and just after discharge home, his medication, part of his medication paid by the patient. And all of transplantation program is under the government and teaching hospitals. The liver transplantation program, we have one big transplantation that is within the Shiraz, is the abdominal organ transplant program. They do intestinal transplantation, pancreas, kidney, and liver. Around more than 600 liver transplantation each year. And around 20% of this number is from living donation. And another program, we have 4 centers in Tehran.
4 centers.
4 centers. All of them, again, teaching hospital, government.
So how many live donor liver transplant centers?
Live
donor.
Now 3 centers. Yes. Because not all of them have permission to do living donor.
Thank you very much.
You are asking me just advice for the Kurdistan to start a liver transplantation. The European Society of Organ Transplant stated that 20 cases per year is a minimum number for the center to keep the learning curve of all subspecialties.
20 cases per year is the minimum.
That's why my advice is to start only in one center.
That's exactly.
To have all cases in this center and then to move forward.
So we need a bit volume to be done in one, not diluted every center, make 1 or 2 per year.
Exactly.
Thank you very much. Later we will comment on rarely there is what's called Iranian model for renal transplant. I read it 25 years ago when Iran in 90s or at the end of the 80s started this program. To solve the problem of donation, the governor will make the responsibility of the families to do, because in other area and in our area till now, people are purchasing, buying organs. Dr. Karzan, yes, Karzan is also a hepatobiliary surgeon and he has an experience in India. If you have a comment, please.
زور سپاس دكتور جان. طبعا I am very glad to have this group thinking of this subject, which we are pushing, talking about every day for the last decade, 11 years. I think this one is a first step toward to have a national program for liver transplantation. And the first step is the most difficult one. And thankfully we have such a great team abroad with experience of starting a program in other locations to help us. They are willing to help us. Representative of Ministry of Health is with us, Dr. Abdullah, thankfully, and he's very, very supportive. I think the key of this subject is with Dr. Abdullah. And I think he's responsible if we have a national program in next few days or no. He will be responsible positively and negatively. And it is a history, I think.
Thank you.
I think it's this meeting is a history for liver transplantation.
Yes.
Liver transplantation for positive or for negative, Dr. Abdullah is responsible. And I am sure that he is very supportive. You know, Dr. Muhammad Umar, for the last decade, I am speaking on this subject. Liver transplantation is so brittle. It's so brittle. It will be going to the first step easily.
Thank you.
يعني بدنا بخلق لهم بتلبكاني جالي موكو طوري لوك سوايا. It's too brittle. يعني you all work on the subject, we work with the subject, but at some point it will be breakdown and it will go to the first square of the. We have to have a national program. يعني if you have a child pulmonary and hepatic failure with hepatitis A virus, what do you do? Do you send the patient to Iran? Do you send the patient to Turkey, to Egypt? He will die 100%. Yani, who will get hepatitis A, pulmonary hepatic failure?
So it is the
Our
time.
children.
Yes, you are.
This is number one. For pulmonary hepatic failure, you have to have a national program. Yani, recipient cases, cirrhotic patients, they have time, they can go abroad, they have money, they go abroad, they have donor, they go for transplantation. But what to do for the fulminant cases? Many very sad histories, stories, a mother with a child with fulminant hepatic failure in the ambulance died on the way to Iran to go to Shiraz. For deceased donor, you have to have a national program, and for fulminant hepatic failure. جا ام قصه بكرديه الله مدامه لزوزو كسا كباسيه كم برنجه كمان هي سلقه كمان هي رونه كمان هي منجله كمان هي او كمان هي خيو كمان هي بس يشي بي بي اتش تو او يا برند منجله يا براخه بخوين زور سباس.
Thank you very much, Dr. Karzan. I think no later. The mic, please.
If I could say a word to Dr. Karzan, there is nothing impossible, and there is no such thing as difficult first step. You could always do it. I could tell you what you want.
Yeah.
You need an interventional radiology. You need a good GI center. You need an interventional even cardiology. You need a financial heavy support.
Yes, this is what he mentioned. Why he said Dr. Abdullah? Because Dr. Abdullah now representing the Ministry of Health. So. Yes, sure. No. What he mean? We need your support. By all means, you are a transplant surgeon. You are working in renal transplant. So for the liver program, we need a support from all the facilities. Now, Dr. Barham, please tell us your. Then we open the discussion for the fruitful points, please. Yes, Dr. Barham.
It's a matter of the help of Minister of Health. Because, as you mentioned, Dr. Abdullah, each patient costing the government around $32,000. If you give this money of 10 patients for example, to the public hospital, definitely we can make the hospital like the most prestigious private hospital. Yani Oparia, Sabi kan Doctor, it is
too much.
It is too much for the patient. Yani if you give this money of 10 patients, we can definitely supply the ICU by a high qualified machine, and we can pay for the team, we can pay for the local nurses, for everything. And we have a hospital now. And it's the time to start in it. We have a very good hospital, although it is not sufficiently occupied. Yes, you visited and you saw by yourself. We will do everything in this hospital. We will do hepatectomy.
New GI hospital.
New GI hospital. We will do hepatectomy. We will do Whipple surgery. We will do everything. We are ready to do the liver transplantation in the public. As Professor Fakhar said, in Iran they will do it in the public. So we need to support the public. And you will pay for the patients. So why this payment not for the public, and to encourage the public to do it, and to make it a teaching program, to make a fellowship for them.
Thank you.
And the other point I want to ask Dr. Ammar from Egypt, the French team that was with you, how much they stay with you, and how it was their stay in your country.
شغال بس احكي يلا ايوه
Back to the first point of governmental versus private hospital. When we started, usually when I have a question like this, I remember our journey of 23 years. When we started, we have a full administrative or full minister support from the Ministry of Health, but we started in 2 private hospitals.
Good.
And when the program is sound program, all subspecialties are in a very good shape. Interventional radiology, surgery, hepatology, pediatrics, everything. Then we moved, now I'm the program director and the only one governmental hospital performing this operation, Nasser Institute. It's a huge one, and we have a program, a very successful program of liver transplantation. But I think to start in a well-equipped hospital and not to exhaust yourself in I don't know exactly what's the governmental hospital in Kurdistan, the level of perfection.
Yeah.
But if you are the same as in Egypt, and I think so, I think it's better to start in a private hospital. Second question, you are asking me how many years exactly. It's very difficult to determine that in Egypt, the French team will stay 2 to 3 years, and in Rio de Janeiro they need 4 years.
Sure.
It's all about the local team.
Yes.
That we are not the team. You are going to make the homework. You and your team are going to do the homework. All the members of the team, a young hepatologist, the pathologist, the anesthesiologist.
No, I mean the 40 cases.
40 cases, we performed 40 cases in 2 years. And at the beginning, this is our story, but it's not applicable everywhere. And Olivier Boileau, the professor who is our mentor, our patron, he started this program in 3 different countries, and after 2 to 3 cases, stopped. It's not his fault. It's usually the local team, passionate team, highly enthusiastic. He wants this program to be successful, and they can deliver all what they need from the visiting team. But I think it's all about the local team.
Thank you very much, Professor Ammar. It's very clear that we agree on certain points. But before I come to conclusion, I like to have opinion of our colleagues, audience. As I say, this is a workshop, so all of you. But please cut it very short. Ustad Maki, shortly, please. I know the topic is so rich, and you can. Yeah. Yeah. Yeah.
You see,
okay, I will.
We were following this program since 1995.
Yeah.
We started even training our surgeons for the liver transplant in dogs. We started. And we have a German colleague, Professor Schiele, came to us. We planned to train, number 1, anesthesia, as you said, all the teams. That was started, 1997. Gradually, we start building up our facilities. Then things went, the war came, and then I was following the program until now, actually. I contacted colleagues from, and of course I knew about Assad, and we met many times. I met with colleagues from India. The secretary of the Indian Society for Transplant is my friend. He's working in King's College. We decided to make I sent a proposal for the Minister of Health. كان طلع شو اسمه وزير الصحة.
مجيد.
لا مو مجيد لا قبل مجيد. This message is all documented. This full program of transplantation, pre, post, and follow-up. The team will come here for 2 years. And that was approved. The minister said, I want somebody to send it to me from the our system, from the society and from the hospitals Nobody did. Nobody did. The surgeon did not do it. So what we do now, this is the program, then the fatwa came. The fatwa, Iran, we have the same fatwas. They approved it. The Saudi, we worked in Saudi Arabia, we did the first liver transplant in Abu Dhabi 2007. It was approved so Saudi approved, the UAE approved. So what we have now here is, I don't know, about this fatwa, I did not know about it actually. But now, the only hope now at the moment is a liver-related transplant. You need a dedicated team. But my proposal is to make a program called Mubadala. Mubadala makes any program in the government, being it the oil or anything, any program, some of it will go to this program to support these, especially transplant, advanced center for training in this country, everywhere here, link all these governments together. This is in my proposal, actually it was written here. So this for the Minister of Health, you can take it actually, and this was well known by the Minister of Health and also the Parliament. Now, I will contact the Parliament now, because I know them, the First Secretary of the Parliament. Because these people they have all private hospitals, by the way. All the private hospitals are run now by the government. You know this, for sure, the same thing here. All the private hospitals are run by the government. All the Parliament, these hospitals, the private hospitals, are their hospitals. So we can contact them. I said, okay, we can go with them. I am ready. This is my country, it's here or there. And I said this many times. I said, what did that came to Dubai, what did they tell you? I'm dedicated as ambassador free. I work in Abu Dhabi. I'm free for this. And I came 3 times to Baghdad. And the first time they nominated me as the director of all the gastroenterology in Iraq. They came to the Ministry of Health. We are very sorry, we don't have money for the consultants. And how much money? $1,000 a month. So that's it. That's enough. Pass this message, please, to the Minister of Health, here and there. And I'll pass it again. Thank you very much.
Thank you, Ustad Maki. Yes.
This week we have His Excellency Minister of Health of Iraq in Erbil. We meet him. We discuss a lot of issues. One of them is a liver transplant. He mentioned we don't have a plan to establishing a liver transplantation in Iraq. I say why. He mentioned that we have a contract with some hospital in India, and we're sending patients there.
Wait. Al-Kafir Hospital, wait.
Yeah.
Al-Kafir Hospital, he invited me. We are 40 consultants they invited to be nominated by Karbala. And I was one of them. That was 4 years ago. Do you know this? And they gave us, of course, because we are the top figures in Iraq. And at that time, I said one thing I wanted from the fatwa. I need fatwa.
Yes.
To fight corruption.
Yes, I know.
You know this?
As mentioned by colleague, if you send patient outside, you will never do anything. This is exactly what I say about the Iranian model for renal transplant. In 80s, they were sending patient outside until they did their program, 80s. So we have to start our program, and as said, the journey of 1,000 miles start with one step.
Transplant,
we already have several steps.
2,000 first renal in our hospital.
I know.
40 years ago.
We appreciate your and other colleagues that did many trials, but now this is the proper time we have to start. Thank you, Ustad Maki. Any other comment or suggestion, please? Ustad Kakil, yes. Please, sure.
Thank you. First point, I am sorry to feel that I have patient dropped at the airport, transplant patient traveling from Erbil to India or coming back, and they come sick and dropped it and died there, more than one patient. This is one. So don't send any patient to do transplant. Should be followed up in the center when transplantation done. This is one point. Second point, for legal issue fatwa, I think now Sheikh Ali Al-Qaradaghi is the head of Ittihad Al-Alami Al-Muslimin. He is from Kurdistan, and can he help?
Ali Qaradaghi.
Yeah, help for the fatwa, to get fatwa to do organ donation. The other point, We have a recent center started transplantation in 2011, and very successful center. We transplanted more than 60 patients now. It is low number because low population, very successful rate. I think the death rate very low, and very few patients died even in the follow-up. I think less than 5 patients. This is because they are following very strict guideline, very strict policy. Only meal and criteria transplanted, cadaveric transplant. This is done. Any patient more than 65, they are not transplanting them, so they have very successful program. So I think I can help, will be ready to support this center here with any policy, with any guidelines, even with the staff or
Thank
the
you. Thank you
center
very much,
there.
Professor Kakel, for your support. ولو نور بريوكر بس قينا أو دكتورة بيش تنابو.
يعني it is a social comment actually. يعني if your God said ومن أحياها
فكأنما أحيا الناس جميعا.
أي قرب سرم.
صدق الله العظيم.
رجل دين. What is the position of the religious man? What he is telling thing against this? So they are doing troubles only, the religious.
Thank you very much. والله يكتب لي أول شيخ فتوى طواو. Just I want to give you a very, very simple example. Blood transfusion is an organ transplant. We are doing blood transfusion thousands. So why you are not objecting? Thank you. Thank you. Yes, please, we have a short comment later, Dr. Manim. Yes, please.
Thank you very much. I am Dr. Ramadan Kocher from the Hague. My question to Dr. Abdullah Saeed and my suggestion also, you need to have a single center in Kurdistan. Nowadays, we have, I think, 3-4 hospitals, private hospitals like Farouk City, like Paki, like Jean. They are preparing themselves for liver transplant. So my suggestion for the Ministry of Health to select one of them because they are good hospitals and they have some and infrastructure is good. Maybe nowadays the public hospital is not so good to build a center for that. To have a collaboration between the private and public centers and to support one of them and to have a full financial support, I think will be a good choice for nowadays.
Thank you very much.
Thank you
very
very much.
clear. He is quite right. This next comment for Dr. Mun'im, and later we come to conclusion. You are right. This is what mentioned by Professor. We should not have 3 centers in Suleimani and 3 centers in Hawler and 2 in Duhok. We will never learn. We need to collect our facilities together. Please.
Dr. Mohammed, I will talk about the ethical aspect. I teach medical ethics in University of Babylon.
Very short.
Like Republic of Iran in Iraq, we are similar to them in considering the religious aspect. It is allowed. The only 2 things which impede transplantation in Iraq, one thing is somebody will buy his liver or buy his organ.
Yes.
This is prohibited.
By law, yes.
Yes. The second aspect, most patients with chronic liver disease, they are poor.
You are right.
From where money they supply? There is, except certain organization campaign.
Thank you very much. I think I point to this. Yes. Mun'im, Abdul Mun'im.
A mistake to allow non-related.
Yes.
We don't want to repeat in the liver. We restricted to only related donors for the liver.
Yes, I think this is the
to
time
be not buying
to
and
change.
dealing.
Yes, thank
It
you.
is very easy. I was 2 years in the ethical committee for renal transplant. Someone came from Al Nasriya to donate his kidney for someone in Suleimaniya. I am sure he's selling his kidney. But when you ask him, he says, no, just I want to serve him. My grandfather was eating with him. So silly. It is not a matter you can by law prohibit it. يعني بقانون ناتواني وقتي خوي بابيري ليرن. So, yes. So this is true, but still by law it is prohibited. It is not allowed to sell.
It's not prohibited.
It
is
is
allowed by the Iraqi and Kurdistan law to donate from non-related.
No, to sell or to buy.
The sale is not allowed.
Yes, this is what I
anywhere
want.
in the world.
But non-related donor is allowed.
It means selling, doctor.
Yes.
There is no way. We want to changing the law. We want to changing law to prohibit it, the non-related.
Thank you very much. Better let people die. What mentioned by Dr. Karzan is just like primary PCI. Someone at 2 a.m. get MI, attack. No time to transfer to somewhere else. You should do it at time, within hour. This is just fulminant hepatic failure from drug, from hepatitis, from other causes, from toxin. It's just like primary PCI for myocardial infarction. So I think it is time we should together, and we appreciate and we thank our colleagues from all the countries nearby or even outside to help us, to support us. And the support could be in 2 directions. We may send people to train there, and we welcome you to visit us and do, starting with our basic pioneers, peoples who are interested really in the field, to start step by step, because we have many people and the number is increasing. It is not a matter of 10 or 20 patients and you did it and everything will be. Every day you have a patient, new patients. So if there is no question, I will not close the session, but I like to have a group photo together. Please come. We will be in 4 rows. The young juniors will be here, some the old sitting, and some in front and some standing back. Please all come in. قلت أنا إما دكتور رسمي شيء ما بقرأ كاكا أم كرسيانا بينا بيشة ولا قال خوتان. Just take your chair to sit on. Please, tomorrow we have to start early. I know tomorrow is Friday. Please sleep early tonight. Tomorrow at 8 a.m. we will be here, please. Thank you very much. That's خوش. جيب الكرسي مالك. Just, yes, please. كاري جانا وكرسي أنا بين. استوقت يوني الدلايب كرسي كان بينا. دي كاكا دي. لا تولدوا كرة ليش هو تبرع قبل ولده. أستاذ مكي تعال بعمل لنا وراسته يلا كراسي كرسي تردانيا يلا بو هستني وش هموتان all together all. أستاذ وريروا حبيبي لا الطوال ما شاء الله. يلا كاكا كزنا مين يتوهموا. دكتور طه تعال. طه كربولي يلا مكانك زين. ورنا السروة بايوست ورنا السروة بعزيكتان لملاوة خير أبي وريني خيراكن دارة توبالة وبرزة قربيتها دوا الشوا. نا كرد أيقرنا ها كان كز هاموي قناصي ده أو يلا اللي راحوا عليهم الفوتو مو هذه أحلى شيء يبقى بالذاكرة مع المؤتمر. كاكا بيمان بلي آمادة بن با أما تيست no, he will do many tests until he will be until it will be ready. أما علي لشوا بوست بيخين السريرة دركبه بآخر بردم ما نقريه بردم ما نقريه. تحب تقعد بروفيسور فخار؟ عفوا لا لويانا بيخر السرع أو بيرشا لويا درسيا عيبينية وبارك الله فيكم. 1 2 smile. Thank you very much for all. Remember, tomorrow at 8 a.m. we will start. Please come early. Thank you.